Our final presentation is comparison of Sacrococcygeal Teratoma presentation and outcome at a high and low middle income hospital, presented by Aparna Panatpur on behalf of UT Southwestern.
Good morning, everyone, and thank you so much for the opportunity to present our abstract comparison of Sacrococcygeal Teratoma presentation and outcomes at a high and low middle income hospital. I would like to thank my mentor, Dr. Hansen. We don't have anything to disclose at this time, and the study was approved by the ethics committees at both Kijabe Hospital and Children's Health. Patients with sacrococcygeal teratomas typically present prenatally or at birth with a sacral mass. Optimal treatment involves early resection of the tumor and the coccyx, ideally in the neonatal period, given the risk of malignant degeneration. Patients in LMIC hospitals often have limited access to safe, affordable, and timely surgical care when needed. And anecdotally, this has been true of children with SCTs at an LMIC hospital in Kenya. We sought to compare presentation and outcomes of SCT patients at an LMIC and a high-income hospital. We hypothesized that LMIC hospital patients would present later and would have greater mortality than high-income hospital patients. This study was conducted via a retrospective chart review of SCT patients managed between 2009 and 2019 in partnership with Kijabe Hospital in Kijabe, Kenya, and Children's Health in Dallas, Texas. We identified 22 SCT patients at Children's Health and 30 at Kijabe Hospital. You can see here that there was a female predominance at both institutions. Interestingly, a few patients were diagnosed fetally in both groups. The median age at detection, which was either reported by the family or by clinical diagnosis, was not statistically different between the two institutions. The median age at initial treatment was also not statistically different between the two institutions. Here we have a table of Altman classification at both of the institutions. Though the absolute and relative number of Altman-4 tumors was higher at the high-income hospital, there was the difference in distribution of tumors by Altman classification between the two institutions was not statistically significant. Here you can see that Altman-4 cases were diagnosed late at both sites. We also looked at delay of treatment and follow-up at both of the institutions. We define treatment delay as the length of time between original detection of the tumor, either as reported by the family or via clinical diagnosis, and first treatment, whether it be operation or chemotherapy. We found that the time to treatment at the low-middle income hospital was significantly longer. We also looked at follow-up and found that the follow-up at the high-income hospital was significantly longer. The distribution of histology at both institutions is shown in this graph. Benign mature teratoma was the most common histology found at both sites. However, the distribution of histology at the two sites was not statistically different. 2 deaths during the study period at the high-income hospital occurred, and 4 occurred at the low-middle income hospital. The 1 death with mature teratoma was unrelated to the tumor, but rather resulted from sepsis after a colostomy closure. Overall, mortality was relatively low, but the percentage did not differ significantly between the two institutions. In conclusion, we found that SCT patients at an LMIC hospital experienced a delay in initiation of treatment compared to a high-income hospital. This is despite fewer Altman-4 tumors at the LMIC hospital and similar age of diagnosis at both hospitals. We also found that the rates of malignancy and mortality were similar. However, shorter follow-up at the LMIC hospital may underestimate actual mortality rates. This comparison highlights the importance of access to care for children at LMIC hospitals with a potentially life-threatening tumor. Thank you so much.
This paper is now open for questions.
Good morning, Rob Baird from Vancouver. Congratulations to your work and to Dr. Hansen for all the great work he's doing in Kenya. I just wondered if you can compare a little bit the surveillance strategies that are available for these patients, whether alpha-fetoprotein and regular follow-up is available at the low and middle income site, and how that's handled. Thanks.
Sure. So our data set actually didn't look at the AFP levels, but in terms of follow-up, we do have mobile clinics in Kijabe that are kind of working to improve access to care for these children and be able to refer them to hospitals whenever they do need care. Our data set in particular did not look at the AFP levels when following up for the patients.
I'll add that mostly that was because it wasn't available generally, or families couldn't afford it if it was available.
Thank you so much for this interesting study. I have a question. Sorry. It's pretty dramatic because that's like almost a 3-month difference from time of diagnosis to time of treatment. Just to clarify, are these babies at the low middle income hospital born all over East Africa, or were they born at this particular hospital?
So interestingly, Kijabe was actually a referral site for patients with myelomeningocele, and so because of that, we actually caught a lot of patients that were referred for the purpose of treatment of myelomeningocele that happened to have a sacrococcygeal teratoma. So it's actually possible that these babies were born all over East Africa.
And then, given this big disparity, if we were to give you like unlimited resources, what do you think would be the highest yield to decrease this time to treatment?
I think given the fact that the main disparity seems to be in the delay of initiation of treatment, I think finding ways to improve patients having access to care, maybe transportation, ability to get to the hospital, I think health literacy could be something else to focus on. There might be patients who may not have known how severe their baby's condition is, and so I think there's a lot of different ways to kind of tackle shortening the time period between when they're diagnosed and when they are able to seek treatment.
Do you have a sense as to what led to those delays? Was that delays for their presenting to the hospital or staffing at the hospital? And
So actually that's something that we didn't look into in this study, but something that I would be very interested in looking into further, just kind of figuring out exactly why there was this delay in treatment, and that can help with instituting measures to maybe decrease that time period between when they're diagnosed and when they're able to be treated.
I'll comment just anecdotally a couple of them. A couple of the pictures you saw. The first picture was a baby who was diagnosed at birth by a very impoverished family, but was told that it was going to go away on its own. Another picture you saw was a 31-year-old who didn't have a problem. So it was only when something started leaking at age 31 that he presented for care. So there's an access of health literacy that she pointed out that I think is important across the LMICs in general.
All right, thank you so much.
Thank you.